Okay, so our first session to start out the day is Innovative Coagulation Therapies, a Revolution in Care. Our first presenter is very well known to everyone in this room. I'd like to warmly welcome David Page. He's the former president of the Canadian Hemophilia Society and a real champion of bleeding disorders in Canada. And he's going to provide an overview of innovative coagulation therapies.
How do I, here's my advancer?
Yeah.
Okay, great. Well, thanks very much for the invitation to start off this great symposium. These are my disclosures, but I also have to say my academic training is in teaching grade 1, 2, and 3. So I have no scientific background. The rest I've had to learn from life experience. And so if it's really simple, that's because it has to be, because I don't have that background. But I'll try to do the best I can. So what I will talk about and will not talk about, I won't talk about current factor replacement therapies or emicizumab, which will be the topic of a lot of the sessions that follow me in this session. I won't talk about gene therapy. So I invite you to come back for session 4 later this afternoon for gene therapy. What I will talk about is factor replacement therapies that are currently in the pipeline, or the therapy, and non-factor replacement therapies, the monoclonal antibodies like MIM8 or MIME8, MIME8's a good name, and what I call the three antis, the rebalancing agents, antithrombin, anti-TFPIs, and anti-protein C. So first, innovative factor, let me start my clock here. So, innovative factor replacement. So the first one is called EFA, and there's a long name that follows EFA, which I can't pronounce. You may have known it as BIV0001, which is a pretty good name too, and it's now called Altuvio in the US. I shouldn't say this, but there's a great baseball player for Houston called Jose Altuve, and I think that is named after him. But there's 3 I's, which make it a bit weird. So EFA is based on Fc fusion technology, and you may know this because it's similar to eloctate. And what Sanofi has done is to add an X10 polypeptide to break through the von Willebrand factor limit on half-life. And this means that it has a half-life of 40 hours compared to, let's say, 18 or 19 for the current EHLs, and 12 to 14 for the standard half-life therapies. And it was approved by the US just a couple of months ago by the FDA, and we're hoping there'll be a submission soon to Health Canada such that it would be eligible for the next tender for CBS and Hemo-Quebec. Tenders, the contracts would take effect April 2025, and so it would have to be through Health Canada process and the health technology assessment processes sometime in 2024. So there's a bit of a rush there. So with a 50 IU per kilogram infusion, that takes people to a 100% level of factor 8 and a 40% level after day 4. So 4 days out of 7 in the normal range. And even at the end of day 7, a 15% factor 8 level. So that's a huge improvement even over the EHLs currently. And the research, the clinical trials have shown a lower annual bleed rate compared to previous prophylaxis, and improved quality of life and joint scores and less pain, no inhibitors in the previously treated patients, but there have been no PUP trials yet. So advantages of EFA or Altuvio. Once a week dosing, which is something we've been trying to achieve, and it has been achieved in factor 9 therapies, but this would be the first time it would be really feasible in factor 8. As I said before, 4 out of 7 days in the normal factor 8 range, a high trough, low annual bleeding rate, improvement in quality of life. Of course, everything has disadvantages. It's still an IV infusion. And it's not effective in patients with factor VIII inhibitors. At least there's no research to show that yet. We move on to the innovative non-factor replacement therapies. MIM8, I don't know how it's pronounced, for hemophilia A. It's a bispecific monoclonal antibody which mimics the activated factor 8. So it's a very similar principle to emicizumab. And in phase 1 or 2 clinical trial results, we have good bleed control in participants with and without inhibitors, showed increased thrombin generation compared to emicizumab, and a potential for a higher equivalent level of factor VIII. And there have been no signals of thrombosis or other serious adverse events, and no anti-drug antibodies. So very promising. It's now in phase 3 trials in 30 countries and 350 participants, so a lot of big trials in people with hemophilia A, but including all ages, which is great, including pups, and all severities, which is helpful, not just severe, and in women and men, which is also good to see. And these trials are estimated to be completed in a couple of years. So advantages, well, it's for those with and without factor VIII inhibitors, similar to emicizumab, sub-Q injection once a week or less, steady state protection, no peaks or troughs, and potentially, and we need to see the data on this, potentially better bleed protection compared to emicizumab, and extremely low level of anti-drug antibodies if we compare to factor VIII. But again, it has disadvantages, only for hemophilia A, not for the other bleeding disorders. Cannot be used to treat active bleeding, may require a factor VIII in the case of bleeding or trauma, and there are no peaks for high-risk activities. Okay, and I said the 3 antis. I'll give you the names of my aunts, but I'll spare you that. My Aunt Magdalene was my favorite. So the principle here is to try to, just like with factor products or with anything else, is to regain hemostatic balance. But instead of adding something, we're going to take something away. So you remember your grade 6 mathematics, -1 times -1 equals +1. That was always a bit of a conundrum to me, but you know, the principle here is that if 2 negatives make a positive, can 2 antis balance each other out? So can an absence of factor VIII or IX compared with reduced anticoagulant activity produce balanced and safe hemostasis? That's the question. So the first one is fitusiran. It's antithrombin. And this has been in clinical trials for, I don't know, maybe 6 or 7 years now. Certainly we've heard about it for the last 10 years. So it's a small interfering RNA agent. There's a nice picture there. It's pretty small because I can't explain it. Maybe some people here can, but as I said, I'm keeping it simple. So it reduces antithrombin, which promotes thrombin, improves hemostasis in the absence of factor VIII or IX, and it's for the treatment of hemophilia A and B with or without inhibitors, and perhaps for other bleeding disorders. And it's once monthly sub-Q injection. So it's now in phase 3 trials, a phase 3 trial with 38 patients with inhibitors, a low ABR, annual bleeding rate. Bleeds are hard to count, so I think perhaps what's an even more important piece of data is the 66% of patients had no bleeds over a period of 8 months. But there were raised ALT levels in a third of the patients. And there were 2 cases of thromboembolic events, which are unwanted bleed clots, and that led to a revised dosing regimen. And in earlier phase 1-2 trials, there was a death. A combination of fitusiran and repeated doses of factor VIII led to a blood clot in the brain and a death in a young person with hemophilia. Now moving into another phase 3 trial without inhibitors. Again, so far it's shown quite a low bleed rate, and half the patients had no bleeds over 8 months. And again, we saw raised ALT levels in a quarter of the patients and no unwanted blood clots. And so the next trial is with and without inhibitors, ages 12 and up, to compare to the current standard of care and to be completed in a couple of years. Now, the second one is the anti-TFPIs, and that picture explains everything. The anti-TFPIs are human monoclonal antibodies. These are hemostatic rebalancing agents that bind and inhibit the tissue factor pathway inhibitor. So less TFPI, more factor Xa, more thrombin, better coagulation. But there were 2 trials with other variations of anti-TFPIs, bifosumab and Bax499, which were terminated in 2020 after cases of thrombosis. The first of these is concizumab, And there again, there were 4 thromboembolic events in early clinical trials leading to mitigation strategies. Phase 2 clinical trials showed an annual bleeding rate of 4 to 6, so quite low, but not really low. A phase 3 trial showed a bit lower ABR, and 63% of people had no bleeds. Now, the big news, a bit of a surprise, it was approved by Health Canada, first in the world, just last month, for hemophilia B with inhibitors ages 12 and up. A very small group, but a group for whom there aren't very many treatment options that are effective. I think there are 3 or 4 patients in the country. And the second one is marstacimab. It's a little bit behind in terms of its timetable in clinical trials, phase 2 clinical trial, once weekly sub-Q. I believe concizumab is once daily. Again, a low bleeding rate, minor adverse reactions, injection site pain. In this case, no thromboembolic events or antibodies, and it's now moving into phase 3 clinical trials. And the third one, SerpinPC, so this, if you see there somewhere in that diagram, it talks about protein C, so this is an anti-protein C, another of the anticoagulants in the coagulation cascade. So this is a recombinant serine protease inhibitor, reduces the level of activated protein C. It's the newcomer to this family, just really entering phase 2 clinical trials. And you see some of the data there. It's a sub-Q injection every 4 weeks. There's been no evidence of thrombosis so far with this rebalancing agent. And it seems to be well tolerated, and the two anti-drug antibodies were not neutralizing. So a low bleeding rate, again we see the same approximate proportion of people with no bleeds over a period, and it's starting bigger phase 2 clinical trials now. And again, hemophilia A and B with and without inhibitors. So the rebalancing agents, the advantages, well, they're sub-Q, either daily, weekly, or monthly, and they have a potential to treat a range of bleeding disorders. They're effective for those with factor VIII or factor IX inhibitors, or should be. They're steady state, just like emicizumab, so no peaks or troughs, and they've shown evidence of good bleed protection. We can't really compare at this point, I think, with what we already have on the market, but bigger studies will show us that. But again, there are disadvantages, and I think the big one, which sort of flashes at us in most of those trials, is cases of thrombosis. And so we don't want to trade one problem for another. So it may not be suitable, again, for certain people at higher risk of cardiovascular issues, cannot be used to treat active bleeding, and may require a factor in the case of trauma or surgery. And again, no peaks. So from research to access, how much time do I have? 1 minute. I'm going to skip some things then. So just to show that research to access takes a lot of time. 4 years ago, we were here at the last rendezvous, and emicizumab was not even available for people with inhibitors. Gene therapies had not been approved, and were in early trials. So things change fast, but sometimes not so fast. This is sort of the picture of how things go through the health technology assessment process. It's called Path to Payment. Just to remind you that inhibitors was 9 months from Health Canada approval to access for those patients, and for non-inhibitors, 28 to 36 months. This is the final slide, and I guess the conclusion is there are lots of question marks there, question marks about if these products will be approved, for which indications they'll be approved, and when they'll be approved. But you can stay up to date. We have products in the pipeline page on our website, which tries to follow these through time, and then the European Consortium does a really nice product review twice a year with a lot more detail on announcements about how things are moving through the clinical trials. And that's the end. Thank you.